Hello everyone, my name is Caleb Roan, and today I'll be discussing clinical decision support systems in the nurse anesthesia practice. I titled this presentation the Digital Co-Pilot because these systems are designed to assist anesthesia providers by organizing information, identifying possible risk, and providing clinical reminders. However, just like a co-pilot, the technology is there to support the provider, not to take control of the case. Throughout this presentation, I'll be discussing how clinical decision support systems affect patient safety, professional responsibility, privacy, cybersecurity, and just the overall workflow of the CRNA. The operating room is a high-risk environment where anesthesia providers are constantly processing information and making decisions. For example, during a single case, we may be administering medications, responding to changes in blood pressure or ventilation, documenting the anesthetic, communicating with the surgical team, and planning for emergence all at the same time. As patients become more medically complex, the amount of information that must be considered also increases. Clinical decision support systems can help organize that information and bring important concerns to the provider's attention at the appropriate time. The goal is not to allow technology to manage the patient. The goal is to make important information easier to recognize while the anesthesia provider remains focused just on that patient. A clinical decision support system, or CDSS, is a form of healthcare technology that provides patient-specific information, alerts, reminders, or recommendations to help clinical decisions be made. These systems are often integrated into the electronic health record or an anesthesia information management system. For example, a CDSS may alert the anesthesia provider to document medication allergies, identify a possible drug interaction, recommend antibiotic redosing during a long procedure, or provide access to emergency protocol during a crisis such as malignant hyperthermia, where things can just kind of get out of hand very fast. The system does not independently determine what is the best for the patient. It presents information to that provider, who can then evaluate, along with the patient's condition, clinical history, and current physiological response, what the best choice of action is. Because clinical decision support systems can influence patient care, the FDA regulates them using a risk-based approach. Under the 21st Century Cures Act, certain decision support functions may be excluded from active medical device regulation when they are designed to support clinical decision-making rather than make decisions independently. In general, the software should use existing clinical information, provide recommendations that a clinician can independently evaluate, and clearly explain those recommendations and how they were developed. The distinction becomes especially important in anesthesia. A system that displays an evidence-based reminder is different from a system that analyzes raw physiological signals and independent direct treatment. The greater amount of the control the software has over the patient, the greater need for regulatory insight, essentially. Professional guidance also emphasizes that decision support technology should complement the anesthesia provider rather than just replace them. The American Association of Nurse Anesthesiology recognizes that these systems may improve medication safety, support evidence-based practice, and assist providers during uncommon but dangerous events. However, the technology must fit appropriately into perioperative care. A system that provides useful information at the correct time may improve performance, while a poorly designed system may create distraction or interfere with patient care. The central point is that CDSS may strengthen practice, but the CRNA's knowledge, assessment, critical thinking, and clinical judgment skills should remain essential in the forefront of how decisions are made. Clinical decision support systems also create important questions about legal responsibility, as you would imagine. Even when a computer provides a recommendation, the anesthesia provider remains legally and professionally responsible for that final decision. This can place clinicians in a difficult situation. Following an incorrect recommendation could contribute to patient harm. On the other hand, overriding an alert may later require the provider to explain why the recommendation was not followed. The safest approach overall is not to automatically accept or reject the alert. The provider should evaluate whether it applies to the individual patient, make a clinically appropriate decision, and document the reasoning when necessary. The computer may provide information, but it does not assume responsibility for the outcome. The provider remains the final decision maker. The legal concerns surrounding CDSS are closely connected to ethical practice. Beneficence requires us to act in the patient's best interest, while non-maleficence requires us to avoid causing harm. These responsibilities do not change simply because a recommendation comes from a computer. When an alert is appropriate, following it may prevent an error. When it does not match the patient's condition, overriding it may be the safer decision. Overall, transparency is important because the provider should be able to understand why the system generated the recommendation. A recommendation should not be treated as correct simply because it came from the algorithm. When clinical judgment differs from the software, documentation should clearly describe the patient's condition, the reason for the decision, and any physiological findings that influenced the care. One of the biggest human risks associated with CDSS is automation bias. Automation bias occurs when a clinician places too much trust in a computerized recommendation or assumes that there's no problem existing because the system did not generate an alert. For example, a provider may follow an incorrect recommendation even though their initial assessment was correct. A provider may also fail to act because they were waiting for the system to identify the problem for them. This risk becomes greater when the clinicians are under time pressure, dealing with interruptions, or managing a high workload. All of these are common in anesthesia practice, as we know. So a quiet computer does not necessarily mean that the patient is stable. The CRNA must continue to independently assess the patient, interpret the monitors, and question recommendations that do not fit the clinical situation. Despite these concerns, clinical decision support systems can provide meaningful patient safety benefits. Medication administration is one important example. A system may identify an allergy, an incorrect dose, a drug interaction, or duplicate medication before the medication even reaches the patient. Clinical reminders can also support evidence-based care. These may include reminders about antibiotic administration, laboratory results, prophylaxis, or other time-sensitive interventions. At the individual level, CDSS may prevent one specific error in one patient. At the larger level, the same system can improve consistency across many providers and many surgical cases. The ability to support both individual and aggregate patient safety is one of the major values of healthcare informatics. Something important to note is that the safety benefits of CDSS can be weakened when the system produces way too many alerts. As we know, alert fatigue develops when clinicians are repeatedly exposed to low priority, repetitive, or clinically irrelevant notifications. Over time, providers may begin dismissing alerts quickly because most of them do not require action. The concern is that a truly important warning may eventually be ignored along with all the unnecessary ones. In the operating room, this problem is especially significant because anesthesia providers are already pressing alarms all the time. We're seeing physiological changes, medications, documentation, and communication from the surgical team. Safe systems should not treat every issue like an emergency. Interruptive alerts should be reserved for situations that are clinically significant and require immediate attention by the provider. Clinical decision support systems depend on access to large amounts of patient information. This might include medical history, medications, laboratory values, allergies, diagnoses, and other protected health information. HIPAA establishes requirements for how this information may be accessed, used, and protected. Technical safeguards include encryption, secure authentication, controlled access, and limiting information to those who actually need it for patient care. However, privacy is not only a technology issue, it also depends on provider behavior. For example, an unlocked workstation, an unintended mobile device, or a patient discussion in a public area can expose private information even when the software itself is secure. Protecting patient confidentiality requires both reliable technology and responsible clinical practice. Cybersecurity is also directly connected to patient safety. Ransomware attacks and other system failures can prevent clinicians from accessing electronic health records, laboratory results, medication histories, and decision support tools. Because CDSS depends on accurate and available data, a system outage may leave the software unable to provide useful recommendations. In a time-sensitive surgical situation, delayed access to information can affect clinical decision-making and interrupt the normal workflow. Healthcare organizations therefore need secure data storage, regular software updates, protected backups, and realistic disaster recovery plans. The provider must also be prepared to continue safe care when technology is unavailable. Decision support should strengthen clinical practice, but it should not become the provider's only source of knowledge, as we've said many times throughout this presentation. For clinical decision support systems to be valuable, they must fit naturally into the anesthesia workflow. A well-designed system provides the right information at the right time. For example, it may display an allergy before medication administration, provide an antibiotic reminder without requiring the provider to search through multiple areas of the chart. This can reduce unnecessary cognitive work and allow the anesthesia provider to remain focused on that patient, which is the most important. CDSS may also promote consistency across the perioperative team by supporting shared guidelines and standardized practices. However, poor integration can have the opposite effect. Excessive clicks, badly timed alerts, or relevant recommendations may interrupt care and increase cognitive burden, as we've discussed with the alert fatigue, for example. The goal is frictionless support. Technology should make the provider's work safer and more efficient rather than becoming another task that competes for attention. In conclusion, clinical decision support systems have become an important part of modern nurse anesthesia practice. They can improve medication safety, provide evidence-based reminders, reduce preventable errors, and make important patient information easier to recognize. It's important to note that at the same time, these systems introduce real concerns involving legal accountability, automation bias, alert fatigue, privacy, cybersecurity, and workflow disruption. The value of CDSS, therefore, depends on how the technology is designed, implemented, and used. The system should provide meaningful support while allowing the CRNA to remain actively involved in every decision. Technology will continue to evolve, but safe anesthesia practice care will always depend on the knowledge, vigilance, and independent clinical judgment of the anesthesia provider. Thank you.